Medical equipment in sub-Saharan Africa is a massive problem. Medical equipment matters because you can't treat patients without it. You can't diagnose them and figure out what's wrong. You can't monitor them when they're in the hospital. You can't offer them treatment, and you can't rehabilitate them without functional medical equipment. So it's essential at every level of the health service to have equipment that's working. Zambia, in a sense, is emblematic of the wider issues with medical equipment in sub-Saharan Africa. So from studies that we did through a needs assessment with VET, and also another study done by the Japanese International Cooperation Agency, we found that on average 40% of the equipment in the hospitals wasn't working. And again, that's equipment that's actually in the hospitals. It doesn't capture what should be there and isn't.
This is a machine we are using for taking the BP.
Okay.
Yes. Because we're on admission, we have to take the BP to know how the blood pressure is. So this is the machine we are using at the moment, and these are digital.
They're digital?
Yes.
Okay, so when a woman comes in labour, is that one of the first things that you do?
One of the first things, because we have to do the vitals, and it's important. We have to do this. So this equipment is very important in the management of a woman in labour. We need to have this.
Okay.
Yes.
And at the moment, in your experience, is this piece of equipment available? Do they break down regularly?
They are valuable, but they usually break down regularly.
Okay.
You can have them, but maybe in 2 or 3 months you need to replace.
Okay.
Which is so costly.
So what happens when it breaks down? Do you send it to the workshop downstairs?
Yeah, usually we send them for workshop where they will do the repairment. Either they are replaced or have to buy.
Okay.
Yes. And if they go, they will take some days before they are repaired for us to continue working.
Okay.
Yes.
So one of the main reasons so much equipment is out of service is because of the lack of qualified biomedical engineering professionals. Those are the people within the hospital and the health system who are in charge of both maintaining the medical equipment and managing it, making decisions about it and planning for it.
And frequently what I would love is if we could do maintenance before they break. It's important. So that as they go around, they will do like routine maintenance. That would be better. Because we only take them to maintenance when they have stopped working.
Preventive maintenance is very, very important because it prolongs the lifespan of the equipment. This is a scenario where you don't wait for the equipment to break down, but you frequently call the equipment to come and look if there is any problem with the equipment, so that if there are any problems, you attend to them before the equipment is completely broken down. The three of us are expected to cover all the wards. And apart from the wards, we also have a School of Biomedical Sciences. There is also the School of Nursing. I think for the School of Nursing, we don't have much medical equipment, but for the School of Biomedical Sciences, there are a lot of medical equipment. Yes. So the numbers are not adequate. And the other challenge, I think, maybe another opportunity that we do receive. We do receive requests from other hospitals. We've attended to hospital in the nearby town of Luansha. We've been called to assist in Chingola and Mufrila. Yes. So when you look at that, the numbers are not adequate. The end users are the clinicians that physically use that equipment on the wards. A good example are the nurses and the doctors. I would cite out one equipment, a suction machine. I think maybe a year or so, we had a problem with most of the suction machines that were coming in because the end users didn't know when to stop using the suction machine.
Yeah, this is a delivery bed where a delivery is conducted.
Okay.
We have a suctioning machine.
Okay.
In case a baby delivered has secretions, suction is done from here.
Okay.
Then this is a resuscitator.
Yeah.
Mostly used to resuscitate babies.
Okay.
With born with a low APGAR score.
Okay.
Then we have an oxygen cylinder in case there's an emergency patient who need oxygen or even a baby. If a baby needs oxygen, we use the same oxygen. Then we also have an incubator.
Yeah.
This is where we put babies who need the service. Though we still have an incubator on the other side. Yes.
Okay.
Then that's supposed to be a suctioning, that's a suctioning machine as well, though not, it's defective.
It's defective?
Yeah, not working.
Okay, how long has it not been working for?
For some time now. You
Yeah.
can see we're supposed to have 2 bottles, suctioning bottles, but unfortunately we only have 1. It hasn't been working for some time.
I think with regards to medical equipment, I think the first thing I would like to point out is we do not have all the necessary medical equipment that we need. And as such, I think we sometimes rely on sending patients outside this hospital. We can maybe look at the equipment in maybe 3 areas in terms of diagnostics, and then monitoring and intervention. So in terms of diagnosis, I think we are relying mostly on the laboratory and the radiology departments. Those are the 2 big departments that we have. And places like casualty, still we need to be supplemented. If we could maybe use this basic ultrasound just there as we are receiving the patient. We do not have that yet. But for the sake of monitoring, critically patients in ICU, we are unable to. And our chemistry machines in the lab has been on and off, such that, if you want to do electrolyte profile, we are unable to do that. And critical ICU patients might need immediate interventions. And these electrolytes are things that change from hour to hour. You need to keep monitoring. But if you don't do that, it would mean that you are just shooting in the air using a shotgun method of treatment, meaning that we may have lost some of the patients because of failure to make those critical decisions at the right time.
This hospital has no endoscopy, upper GI or lower GI endoscopy, no cystoscopy equipment. And for patients, we have to send them 350 kilometers from here. One of the challenges we have in our environment is with blood. We relatively are always short of blood. And one of the things which can help us reduce the requirement for blood transfusion is a cautery machine. And I think at the moment we are running on 1 machine.
Yeah. So in this case, whenever you have such
Maintenance is something that we cannot just totally ignore, because even the old equipment that we have, maybe you might, if you had to take an inventory and look at each particular equipment, you may find that they are quite old, and yet some of the equipment is usable. So as such, if we've got good biomedical scientists that are able to work on the equipment and put them back to use, I think that's more important also. Because even when you look at our diathermy machines, we may have maybe even up to 5, 6, but we are only using 1. Meaning that even that same one we are using, it had been down for some time, but they had worked on it. So if they are very good at repairing, maybe we may even salvage 3 or so more, and then it would ease our work.
Zambia, like most developing countries in Africa, has a lot of challenges in terms of hospital equipment maintenance. In that, we don't have locally trained manpower in terms of hospital maintenance. The few of the maintenance engineers who are within Zambia now have been trained abroad.
So in an assessment that I did for THED in Zambia, visiting different hospitals, I interviewed 14 different maintenance staff, and only one of them had had any training in biomedical engineering prior to joining the workforce. So he was the only person who had actually been trained on and seen medical devices before starting to work in a hospital, and his training had taken place outside of the country. So one of the main reasons there's such a lack of trained personnel is because there are very few training programs in Africa to train biomedical engineering professionals. It's a huge gap.
THET launched a medical equipment program to try and address some of the issues around the shortage of biomedical engineers in Zambia and other African countries in 2012. under the Health Partnership Scheme. And so in Zambia, the partnership between Guy's and St Thomas's in London and the Ndola Hospital in Zambia has been able to link biomedical engineers from the UK with their opposite numbers in Zambia at Ndola Hospital. And the purpose of that is to be able to strengthen the skills and knowledge of the biomedical engineering team in Ndola. I
come from a background of mechanical. I've done medical equipment in-house training. So you'd find that we, if I may use the word, we are not 100% there. So we'd, once in a while, would need external assistance. Like the issue of Peter Cook and Rashid, they've come in, we gave them specifically some equipments that were giving us a lot of problems, a lot of challenges, because we don't have the experience to look after them.
So this hospital, Guy's and St Thomas's, have got a link with Ndola hospitals. My involvement to date is having applied for the grant funding from THET for a medical equipment project, and have been on one support visit to Ndola with my colleague Rashid, where we help do various repairs. And we're also looking at procuring test equipment for the Children's Hospital, because they've got a workshop set up but no test equipment inside it, and various other projects going on from here to support them with their equipment problems.
So you have to start thinking about being a little bit more innovative in the way that you operate and work. Maybe not quite to the same standards as we do in the UK, but it's a question of if you don't do anything, they've got nothing left. So you've got to do something. So you try and find maybe a slightly different engineering solution to their problems.
Medical equipment technicians should be able to educate the end users on how to use that equipment, how to care for that equipment day to day. So when people like Peter come in and do the training, at times it becomes like a refresher course. But again, like I mentioned earlier, every little training that we acquire goes a long, long way.
The type of training which is happening at Ndola Central Hospital is most welcome, and Zambia as a whole country, we are benefiting in that we are having exchange programs with the biomedical engineers who have come from the UK, and we are getting a lot of ideas and updated information in terms of management and maintenance of hospital equipment.
When you come here, you really begin to think, well, crikey, we're quite lucky we're in the UK in terms of what we've got available and how easily we can obtain it. Here, any part seems to become a major exercise. The standards we work to, again, the management standards and so on have been much more developed, and we're hoping that they will develop similar things here. It's like buying service manuals, spare parts kits, things like this, when you're procuring the equipment, and actually thinking about what you may need in the future and getting those in right at the front end.
The ultimate aim is that they could look after themselves for medical equipment maintenance. So we're not just doing the troubleshooting and showing them how to do it, but we're also talking to them about the procedures and the management of maintenance, and particularly the purchase of items from abroad or spare parts and where to source spare parts. So if you like, there's a very simple, the best option for them for buying spare parts or tools is to get things from Ndola or from Zambia or from distributors here. But after that, there's also an element of they have to be able to look overseas for some of the more specialised parts and equipment that they can't do without. And so there is a whole procurement interesting angle on getting parts here that is probably their biggest problem right now.
Press desiccate, go on.
You have to change.
Go on.
What do we to change?
300 ohms load, it's the same. It's the same. Go on. 507s, that's good. This one. 516, that's good. And this one?
The systemic issues, or the kind of underlying problems with getting equipment or getting spare parts, are the single biggest, to my perception, and also some of the evidence I've seen people present, the biggest limiting factor on support of medical equipment in developing countries, or certainly the two I've seen, which is Nigeria and Zambia. And you can tell from surveys that have been done or from asking people, usually the local staff are actually very good technically, or they have a large amount of technical knowledge equivalent to many technicians who work in the UK, because they see more technical challenges and because they've been through educational courses that are almost equivalent now. But what they don't have is the same level of knowledge of the commercial background or the suppliers or which manufacturer was bought by who, and they don't have access to the same kind of facilities like ordering something and having it turn up in 24 hours. So they don't get the same level of practice of spending money and getting the things with it, and they also don't get the immediate contact with suppliers. We in the UK get lots of contact with suppliers because they come in here every week and try and sell stuff, but you don't see that in Zambia, so you don't get the constant stream of supplier information.
The issues, amazingly, are very, very similar. You know, we're always thinking about the cost and how we're going to manage to maintain everything within the budgets that we're getting, and in actual fact they've got the same issues there. You know, it might be a difference in scale, but it's still a cost issue and being able to get hold of the spares. The one thing where we've learned is we're quite lucky here. We've built up quite a good database of contacts and so on, and that's part of when we commission the equipment, so we know who's supplied it, who's manufactured it, and where we can get spares from. So we keep all that data on a database, so if anybody needs to, even if I'm not here in a year's time, somebody else can get access to that data and contact the original supplier or the manufacturer to get hold of the right items. That sort of stuff, they're slowly starting to develop over there. They didn't have a huge database, but we managed to set something up starting off in Excel, and if the numbers get much larger, then they may need to move on to something that's a bit more specifically set up for them. I think there's the other bit is, I suppose, we're actually looking actively to see what we can sort of pass on to the hospital of useful equipment that we may not use any longer, which normally would have gone through some sort of second-hand sales and scrapping process, and people like this wouldn't have got a look in, because you get people who are going to be dealers who would buy that, check it all out or whatever else, and then resell it at value to either places like this or elsewhere, so probably private concerns, so they wouldn't get a look in probably. So, you know, we are actively looking to see what equipment we're pulling out and how we can actually use it. Because again, because we know some of the maintenance and other issues that go with it, we're actually considering those before passing the equipment on.
Up to 80% of medical equipment in sub-Saharan Africa is actually donated equipment. So it's donated to hospitals here, often by very well-meaning individuals and organizations, but the majority of that donated equipment is never put into service because the donors haven't consulted enough with the recipients and haven't thought about whether or not they're sending the equipment with spare parts and with training and with support for the people here in the hospitals who actually need to be able to understand how to operate and take care of the equipment.
No, the donation of medical equipment, it's a good thing. But at times I think we are not given an opportunity where you would sit down with a donor and ask some little things they overlook, like the issue of a manual. To us, that is very, very important, because it's from the manual that we can be assisted even to come up with a preventive maintenance plan and other issues like educating the end users.
I think a lot of people generally want to help their link hospital, and they think that any equipment, if it's in good working order, would be a significant gift for the recipient link hospital. But sadly, that isn't often the case. If the donor cannot use the equipment, it becomes a disposal issue, and what is more, it can actually cause harm.
There's a lot of inappropriate donations. That's the first thing. I've heard of situations where whole containers turned up from overseas. The president of the country's come and virtually everything in the container was worthless. I've heard of situations where a diathermy turned up and on it said, "No good, broken, sent to third world." You know, completely crazy and inappropriate things. That said, you know, the developing world exists of donated equipment. So there is a significant percentage, goodness knows what it is, that gets through and is delivering. So I think that's important that we recognise that. However, there is an immense amount of complete and utter rubbish that is sent that is absolutely worthless, will not do anyone any good at all, and is creating significant problems from just a waste point of view. Sure, now these are challenge incubators actually. It's something that we're quite often asked for, and there's a whole bunch of issues with them.
Yeah.
If you get the right unit, they're actually quite simple, you know, and some of them, there's loads of inappropriate equipment there that shouldn't be happening, and it's all there because people haven't asked the right questions, they haven't looked at their objectives, and they've been more interested in a well-motivated way of making themselves feel good as opposed to thinking about the outcome for the receiver.
Over the years we have learnt quite a lot about best practice and things to look out for. In the beginning it was very much a case of looking for equipment that we knew would have a use in Tanzania, and with support we could assist people to use it, but we did realise that there were more issues to be taken into consideration. For instance, the suitability of the equipment within the service area at KCMC. Could they get the consumables? Did the engineers know how to repair it or maintain it? Could they get spare parts? There's a lot of things that you have to take into account with donating equipment. And from the perspective of the Trust, we were wanting to ensure that the donations would be used.
What's important all the time in this work is that the equipment that you are getting has to fulfill the objective to which it's required. So an ultrasound has to work long term, you know, and it has to work in that environment and be appropriate for the skill level of the user. So that's all the time in this work. You have to be asking, what are you trying to achieve? And I might add, that's not about making the donor feel good. It's about delivering something that will achieve at the end for the end user. Designed so that you can. But it's just about knowing what question to ask. And that encourages the end user because they are excited that they are being asked the right questions, and because they know that means that when the kit arrives and hard-earned money and effort has been spent in getting it there, then it's going to do, as they say, what it says on the box.
The engineers at Northumbria always thoroughly check all equipment donations to make sure that they're in full working order, that they've got a reasonable lifespan to come, and therefore they're safe for shipment. We also make sure through the engineering department that all of the items that you need to send out with equipment, such as leads, operational manuals and repair manuals, anything that would be helpful for the recipient to have would be sent out with the donation, so that everything is there for them to look after that equipment, and hopefully it will give them a lot of years good use.
Set have been developing a toolkit which will help organisations and institutions in the UK to decide whether to donate, and if so, how to do it appropriately. So what's really important to us in this is that the end result is actually better healthcare for patients in the partner institution overseas, and we hope that the whole process of using the toolkit will help to improve communication between partners and make sure that appropriate steps are taken when dealing with donated equipment.
This came from via, I think it was used at some point in the military, and as you can see, it's absolutely, it's no good to send it. Relationships with the recipients, with customs, with everyone involved in the whole process are the absolute fundamental success. If you don't, like anywhere, have a good relationship, then everything's going to go wrong, basically, because you need to understand what is required, you need to have trust, you need to make sure that all the communication channels are open, because that's when things go horribly wrong in terms of freight coming through. People need to know when it's coming through, they need to know how it's coming through, contact details need to be in place so that everything's done in advance, so there's no hold-ups, because hold-ups in customs often means money, And there's no reason why we can't get all these things planned in advance so they will go through. So the whole relationship thing is absolutely vital.
So one of the things that's really important in the partnership model that we promote and we encourage people to use is that it's an equitable relationship, so that it's not a case of a project being UK led. It's a case of it being jointly developed on the basis of the needs of the overseas partner. So within the context of medical equipment and biomedical engineering, it means that the right equipment is in place at the right time and the training is given so that it's ultimately of benefit to the patients and the quality of patient care in the partner hospital overseas.
Yeah. Can we get batteries like this locally here?
Yes.
So could we get an equivalent from here?
My desire is to have a situation where each particular ward has basic medical equipment, because you'd find I would give you a good example. There is what we call a medical filter. This is a place where when somebody comes in the casualty, you'd find they don't even have basic monitors to monitor the patient before they are transferred to other wards. So that is my desire, and that would be a very nice thing.
And show you
Of late, at least medical equipment section has been appreciated. Unlike maybe 4 or 5 years ago, the impact was not so much, but people have realized that this unit is very, very important.
Yeah, the partnership between Guy's and St. Thomas, Ndola Central Hospital and Arthur Davison Children's Hospital is a great example of how biomedical engineers from the UK can come to places like Zambia and share their skills and offer training. So one of the initiatives we've been working on in Zambia is to develop a new diploma program for biomedical engineering technologists at Nortec College. So this is a 3-year program that'll graduate people at the technologist level, and what those graduates will be able to do is both do the maintenance on the equipment in the hospitals and also do management of the equipment. So they won't only be fixing things, but they'll also be feeding into equipment decisions and planning and be actively engaged within their hospitals.
The program which we have developed at Nortec is a most welcome project which we have all of us Zambians been waiting for to take place, because this has been, I think, long overdue. It has come at a good time, and all of us are happy about it. This program is going to help local engineers to have well-trained human resource in terms of hospital equipment.
So we also need to put together a training lab at Nortec College where the students will actually be doing all their hands-on learning on maintenance of equipment in years 2 and 3 of the program. And so we need to have the lab refurbished, we need to get tools and test equipment and workbench space in, and we also need the medical equipment that students are going to be trained on over the course of the program. So here within Zambia and abroad, we're talking to governments, we're talking to cooperating partners and to private sector donors to try and pull all those pieces together. Just to put into perspective how much resource is required, the whole amount of resource required to put the lab together is a small fraction of what's spent every quarter here in Zambia on maintenance contracts for medical equipment, and it's a tiny percentage of what lots of big donors spend when they're procuring new equipment for their initiatives. So it really is a small amount of money compared to other initiatives that will go a long way.
There's a part of me that really admires the amount of stuff that they get faced with from day to day, which is not at all easy. It's an interesting feature of these weeks, going on support visits, that often we learn as much or more as the people here who we come to work with.
Our vision for biomedical engineering in Zambia is that it grows as a profession, it becomes more recognized. Biomedical engineering professionals here and more widely
all over need to be recognized as human resources for health. They're a very critical group of personnel within a hospital and a health system, and they need to be recognized for that so that they're given the resources to be able to plan more effectively and contribute more effectively both to maintaining and to managing equipment.